Well, thank you so much for inviting me to present today. I'm excited to be here and really enjoyed listening to the last session and hearing all the questions from our participants today. So what I wanted to do is really kind of give a general overview of both the epidemiology and risk factors for breast cancer in men, as well as treatment, and then talk a little bit about, just briefly touch on some of the research we've done through the international collaboration. So starting with the epidemiology, breast cancer in men in the US is about 1% of all cases, which actually I think is higher than a lot of people think that it might be. So we definitely see quite a few cases of breast cancer in men, even though people aren't thinking about it. And for 2023, we estimated 2,800 new cases and 530 deaths. We do know that the incidence varies by race and ethnicity, and in particular, in the US at least, we are seeing higher rates in African-American men, both higher rates of the disease as well as higher mortality from the disease. And, because of the lower prevalence of breast cancer in men than women, and probably also because of the lack of attention, a lot of the literature, research, clinical trials, treatment really do focus on female breast cancer. So what is the difference between breast cancer in men and breast cancer in women? We know that on average, men are diagnosed a little bit older, so about 5 years older on average. And we also have seen, looking at the biology of the disease, that some of the molecular and pathologic features are different between men and women. So specifically, men on average have lower grade disease. They often do present with later disease, so higher stage of presentation, and are more likely to have disease that's hormone receptor positive. So by that, I mean either estrogen receptor positive or progesterone receptor positive. So what are the risk factors? I say that's probably one of the most common questions that I get in clinic, is people come in wondering, as anybody would, like why they got this disease, what were the factors that might have predisposed them? And as with women, in most cases, we actually don't really know the answer for why any individual gets cancer. But we do know, when we look at big population studies, what some of the risk factors are. So these do include increasing age. So again, for men, the older you get, the higher your risk is of developing breast cancer. That doesn't mean that we don't also sometimes see it in quite young men, though. Being African-American or Black, and having a family history of breast cancer. We also know that genetic germline mutations that increase risk of breast cancer can predispose to breast cancer in men as well as breast cancer in women. And you do have a talk later today, coming up on the genetic causes of breast cancer in men. The one gene that we think about the most is BRCA2. That's probably the one that's most strongly linked to breast cancer in men. BRCA1 also is associated, but has a lower risk. And even lower are genes like CHEK2 or PALB2, which can also be associated. And again, we are going to come back to that, I think, later today in a talk. One of the environmental exposures that's pretty clearly linked is exposure to radiation, and I'll come to that in a later slide and talk more about that. And then endocrine factors, including an increase in the estradiol levels in your blood, genetic syndromes such as Klinefelter, gynecomastia, liver disease, obesity, and testicular abnormalities, in that some of these can relate to levels of estrogen. So this is I think this was a really nicely done study looking at whether or not elevated estradiol levels did predispose men to developing breast cancer. So this was the Male Breast Cancer Pooling Project. It was a case control study where they looked at 101 men who had developed breast cancer and 217 controls. And then they measured a whole host of different hormones to try to determine which hormones might be associated with risk of breast cancer. And what they found was that androgen levels were not associated with breast cancer risk, but circulating estradiol levels were associated. And so for the men with the highest level of estradiol versus the lowest level, had almost 2.5 times the risk of developing breast cancer. We've also seen similar data or even a stronger association for men with Klinefelter syndrome. So Klinefelter syndrome is a genetic disorder where men are born with two X chromosomes. So instead of XY, they have XXY chromosomes. And this does result in higher levels of estradiol and lower levels of testosterone. A British study showed that men who had Klinefelters had almost a 1% risk of developing breast cancer. And a Swedish cancer registry study showed that men with Klinefelters had a 50-fold increased risk. So this is not a very common condition, but it does have a strong increased risk. I think radiation exposure is probably one of the other very clearly established risk factors for breast cancer in men. And it's interesting because I feel like anecdotally, I saw this quite a bit in my clinic. So I've certainly taken care of patients who've been cancer survivors. So for example, had lymphoma and received chest wall radiation or mantle radiation as part of their treatment for their previous cancer, or had leukemia and had radiation as a part of that. I've also seen men, and this hasn't happened as much recently, but I think radiation was more commonly used maybe 50, 70 years ago. So I took care of a young man who, when he was an infant, had an enlarged thymus and had that radiated. I've taken care of, this was a long time ago, but an elderly gentleman who had bad acne on his chest as a teenager and had radiation to his chest for that. And maybe one of the more interesting ones was a patient I had years ago whose parents owned a shoe store, and they had one of those machines where you could go in and it would x-ray your foot, and that would tell you how big your shoe size was. So he would like play in that with his brother, and he ended up developing bilateral breast cancer. So whether that was a cause or not, it's hard to say, but I guess I feel like I come across these anecdotes quite a lot in my clinical practice. But the real data is here on this slide.
This is great.
And
this is the first session. We have 27 people logged in out of 60, because people aren't going to be there for the whole day. So that's great.
This was looking at Japanese atomic bomb survivors. And so they followed 45,000 men who, survived the atomic bomb, but were exposed to varying degrees of radiation. And they were able to show really a dose-response relationship. So the more radiation that men have been exposed to as a result of the atomic bomb, the higher the risk of developing male breast cancer. So very clearly showed that radiation exposure, large doses of radiation exposure, could increase the risk. So how do men typically present with breast cancer? Well, the most common is just a painless lump, typically under the nipple. Sometimes men will come in with nipple discharge or nipple bleeding, or skin or nipple retraction, where the nipple's kind of pulling back in, or even if it's more advanced, ulcerations on the skin. Men really undergo very similar diagnostic workup as to women. Even though there's not a lot of tissue, men, as I'm sure you guys all know, can have mammograms. We do mammograms in male patients, ultrasound if needed, and biopsy. But unfortunately, as you heard before, men are more likely to present with more advanced disease. And this is probably a couple of different reasons. I mean, partly, I think it's lack of awareness. And partly is that we're not screening with mammograms as we are for women, which I think is appropriate, but it does result in disease being picked up later. What about the histology? So this is really describing what the pathologist sees when they look under the microscope at the tumor. And for men, the vast majority are invasive ductal carcinoma. So this means that the tumor grows out of the ducts in the breast. And that makes up 85 to 95% of breast cancer in men versus 60 to 70% in women. We also see maybe between 5 and 10% that have non-invasive cancer, so ductal carcinoma in situ, and we see more papillary cancers in men than in women. Lobular cancers are less common in men, probably because the breast really doesn't form the terminal lobules as they do in women. This is some of the results from our International Male Breast Cancer Program that was published by Dr. Cardosa, who's going to be speaking to you next. So this was from the first part of it, and I'll talk a little bit more about this program at the end. So we ended up with tumor samples from almost 1,500 male patients, and then had them all the specimens underwent a central review by a pathologist. So it was all very standardized. And what we found is that almost everybody was estrogen receptor positive. So 99% of the tumors were estrogen receptor positive. 82% were progesterone receptor positive. And interestingly, with the last talk, 97% were also androgen receptor positive. So this is very common in the male tumors. 61% had low measures of proliferation, and about 9% were HER2 positive. So this is a little bit less than we see in women, but it definitely is a subset of breast cancer. And most of them were these luminal subtypes. So these are kind of the estrogen receptor positive types of breast cancer. So let me go back. Just to point out, almost none were triple negative, 0.3%. So triple negative is a very rare phenotype in male breast cancer. I think I've seen maybe one over the course of my career, and that was a tumor that seemed to be radiation induced. So that's, if you see, for physicians, I think if we see a patient with a triple negative tumor, the first thing I'm wondering is if it's actually a metastasis to the breast from another site in the body, because it's so unusual to see for a breast cancer. So how do we approach treatment for men? So, generally, I'd say most of these approaches are pretty similar, except endocrine therapy are pretty similar between men and women. So most men end up receiving a modified radical mastectomy with either an axillary lymph node dissection, which is where they take out all of the lymph nodes in an anatomic area, or sentinel node biopsy, which is when the surgeon does an injection, sees which lymph nodes the tracer goes to, and only removes the first lymph nodes. Breast conserving therapy is possible for some patients, but I think is underutilized somewhat in male patients. Generally for radiation, there's limited data, but we use similar guidelines for men and women. Chemotherapy, also limited data, but similar guidelines. And for endocrine therapy, tamoxifen really remains our standard of care. And I'll touch on each of these coming up. So as I mentioned before, mastectomy is by far the most common surgical procedure for men. And I think this is because the tumor typically sits, or not always, but very commonly right behind the nipple. And so often when the surgeons are operating, they have to take the nipple anyway and end up doing a mastectomy. However, I think that we have probably underestimated some of the issues with cosmesis, and breast conserving surgery is sort of coming up more and more as an option for some patients with breast cancer, especially if their tumor is more off to the side and not sitting directly under the nipple. And it does seem to be associated with equal outcomes. I think in the picture here, which is from the Houston Chronicle, of a patient who was treated with breast cancer, he was a very slender gentleman, and maybe it was not so obvious, but I certainly have patients that with a mastectomy, it can be more disfiguring than one might initially think. I think people think, oh, it's a man, not a woman, so it's not going to be so obvious. You're not going to see it. But for some men, it is not only the scar on their chest, so if they were to take off their shirt or go swimming, but really visible even when they are dressed, that there's an asymmetry between the two sides. And so, I think there is a real increasing interest in doing a better job at paying attention for cosmesis for our male patients. And that really includes, considering breast conservation when it's feasible and if it's something that the patient wants. I mean, typically, if somebody has breast conservation, then they also will end up having radiation afterwards. Nipple sparing or skin sparing mastectomies can be done, as they are for female patients. And if we can proceed with breast conserving therapy, sometimes we can end up with fewer adverse events, such as lymphedema or numbness, decreased range of shoulder motion, especially really with the axillary surgery. So I think kind of big picture, I think it is just important for us to think about the cosmetic results, because they can make a significant difference to male patients, just as it does for female patients. Radiation therapy is interesting. I think although the guidelines are similar, what we see when we look at national data sets and what we also saw in our international project is that radiation tend to be underused in men with breast cancer. So if we look at the SEER data, so SEER in the US is our cancer registry, kind of doesn't cover the entire US, but it's sort of our national registry of cancer. And so for men with stage 1 breast cancer who received breast conserving surgery, only 42% received radiation. So this is kind of surprising, because you would expect it is standard for men and women to get radiation after breast conserving surgery, unless they fall, into they're, very old or, have other kind of medical conditions. Generally, we think, though, that adjuvant therapy, radiation therapy, should follow the same guidelines as we use for women. Chemotherapy, also, we really extrapolate the data that we have from women. And so when we think about the use of either adjuvant chemotherapy, which is chemotherapy after surgery, or neoadjuvant chemotherapy, which is chemotherapy before surgery, or HER2-targeted therapy for patients with HER2-positive breast cancer, when we offer these treatments if we think a patient's at substantial risk for recurrence and death from cancer, and that the treatment would be likely to lower those risks. There aren't any randomized trials of chemo, no chemotherapy in male patients, although, as mentioned before, we are seeing efforts, and very successful efforts actually, to have more men included in the overall clinical trials. So although we'll never see trials of 1,000 men testing a new chemotherapy, but we are seeing inclusion of men in the same trials that women are included in, which I think is a huge step forward. And for male patients, as same for female, but I think it's always important to balance the potential risks as well as the potential benefits of chemotherapy. And this is particularly relevant for some of the male patients who tend to be older at diagnosis and potentially have a shorter life expectancy in general. So just making sure that we're offering it to patients that's appropriate and that are likely to benefit. This is the only prospective study I'm aware of chemotherapy for male breast cancer. This was a study done out of the National Cancer Institute many years ago. And you can see this because the treatment was 12 cycles of CMF, which is not even really anything that's been standard in the course of my career. Patients were followed for up to 22 and a half years. And I think one of the most interesting things of this was really the high rate of second primary tumors. So we do know from registry studies that men with breast cancer are more likely than men without breast cancer to develop second primary tumors of breast cancer, but also some other tumor types such as melanoma, for instance. One question that often comes up in clinic is whether or not we can use the Oncotype DX test in men with breast cancer. And I think this was really still probably an unanswered question. So what the Oncotype test is, a piece of the tumor is sent off to this company that runs the test, and they look at the gene expression of that particular tumor. And from that, they have an algorithm that comes up with a score. So if you have this test, you get a score back that's between 0 and 100. And whatever that score is correlates with the risk of recurrence of breast cancer, and also tends to correlate and identify patients who benefit from chemotherapy versus patients who don't benefit from chemotherapy. So this is being used more and more in women, particularly those with early stage ER-positive breast cancer. But is this applicable to men? And I think maybe is the answer, but the data are pretty limited. So this table shows some of the studies that have looked at the Oncotype test in men with breast cancer. So there was a study, again, from the SEER registry. So they did a really nice data linkage but for the cancer registry data and Genomic Health, which was the company that was doing the Oncotype testing. And then they looked at the distribution first, just so look at what % of men and women had low risk scores, intermediate risk scores, and high risk scores. And what you can see is the distribution in men is not too different than the distribution in women, although men were slightly more likely to have higher risk tumors than women. And these findings were very similar to those for a smaller series from Israel and a series from the National Cancer Database. The second part of that, so we looked at the distribution, but the other question was, does it actually predict outcome in male patients as it does in female patients? And for this, the data become smaller. But if you look at the SEER data for men, you have 322 men who had testing and had 5-year breast cancer survival. And for the low risk, the survival was 99%. For the intermediate risk, the survival was about almost 96%. And for the high risk, it dropped significantly down to 81%. But we do have to remember these are based on very small numbers. So the high risk group, for instance, only had 42 men in it. So I don't think the data are, obviously they're not nearly as strong as they are for women, but it does seem to at least correlate with prognosis with high risk patients by oncotype, high risk male patients identified by oncotype having worse prognosis. So what about endocrine therapy? I think this is sort of the obvious area where there may be differences in treatment between male and female patients. So as I mentioned before, most breast cancers in men express the estrogen receptor. And tamoxifen really is the therapy of choice. So we know from treating men in the metastatic setting that tamoxifen can be very effective as a treatment for male breast cancer. But it clearly does have side effects. I think from what I see in clinic and from what I've seen published, the side effect profile in men and women is similar, but maybe not identical. So for my male patients, honestly, the number one complaint that I have from people come in or side effect that they tell me about is leg cramps. So I think this happens in women also, but I think this happens quite frequently in male patients. They also can develop hot flashes. I sense that that's less common in men than it is in women, but definitely happens. It still increases the risk of cataracts. It increases the risk of blood clots. And actually, men may be slightly more susceptible to developing blood clots on tamoxifen than women. And some men do report a decrease in libido or sex drive when they're taking the tamoxifen. And as you heard earlier, this has led to high discontinuation rates with tamoxifen, where 20 to 25% of men will stop taking therapy before they reach their 5-year mark. So what about adjuvant aromatase inhibitors? So, these are drugs that we use commonly in postmenopausal women. And what they do is they block the conversion of androgens to estrogens. So I think at first glance, people thought, oh, these might be great drugs for men because maybe a man would be more like a postmenopausal woman where these drugs work really well in. But I think there's still a lot of questions about the use of aromatase inhibitors in men. They've been studied in the endocrinology literature. So just looking at men who took, for example, anastrozole and the studies have drawn hormone levels over time. And they do show that anastrozole decreases estradiol levels in men who are taking it. It also does result in an increase in testosterone. And the estradiol levels, though, while they are suppressed, they aren't suppressed as much as they are in women, I think because of the still continued production of testosterone. So typically, if we're using anastrozole, we will add a GnRH analog, and this really allows us to completely reduce the levels of both the estradiol and testosterone. There are also 2 registry studies, which, while there were not that many male patients in it, but both of them found that men who took tamoxifen in the adjuvant setting did better than men who took aromatase inhibitors in the adjuvant setting. So, these are not randomized studies, but they do strongly suggest that the outcomes are better with tamoxifen. So for all of these reasons, tamoxifen really has remained our standard of care for men with breast cancer. This is a really interesting study that was published just a couple of years ago now by the German Breast Study Group. So they did a phase 2 randomized study with the main endpoint of looking at estradiol levels in male patients. And they compared 3 different approaches. So one was using tamoxifen alone, one was using tamoxifen and a GnRH analog, and one was using exemestane, which is one of the aromatase inhibitors, and a GnRH analog. And this it was relatively small, enrolled 56 patients. And what this showed, this is a little bit of a complicated slide, but the panel on the top left is looking at estradiol levels. The second panel is testosterone, and then the bottom ones are FSH and LH. And then there's 3 different time points. So the first time point is baseline, then 3 months, then 6 months after starting treatment. And you'll see for estradiol, for men that took tamoxifen, the estradiol levels went up modestly, not a lot, but slightly when they were on tamoxifen. But if they added a GnRH agonist, the estradiol levels went down, either in combination with tamoxifen or in combination with exemestane. And this is what you'd expect based on the mechanisms of these drugs. It doesn't prove that that's a more effective treatment, and this drug wasn't big enough or have long enough follow-up to actually look to see which was more effective. This was really only looking at drug levels. So again, the GnRH added to tamoxifen or aromatase inhibitor led to a decrease of estradiol levels versus tamoxifen alone. I think what was actually, to me, one of the most interesting things in this study is they did a quality of life questionnaire along with each of the different treatments. And so they did find a strong association between sexual function and quality of life with decreased estradiol and decreased testosterone levels. So the men that were on the GnRH agonists had worse sexual function, worse quality of life. And interestingly, actually, men on tamoxifen alone in this study, and remember, this is quite small, but on average did not report a change in sexual function. I can say in clinic, I certainly have quite a few patients, though, that do tell me that they're experiencing these side effects. So I don't think the study was big enough to definitively answer that question, but it was reassuring that it was not not everybody has a major decline in sexual function. So what factors predict outcomes for men who are diagnosed with breast cancer? I'd say generally these are the same as for women. So unfortunately, race still is a predictor of worse outcome, advanced stage, higher grade, lymph node involvement, larger tumor, and potentially hormone receptor and HER2 status. So those are a little harder to show in large studies. Okay. We also see for breast cancer in men, as we do for women, that unfortunately patients with low socioeconomic status and worse health insurance in the U.S. Have a higher mortality rate, which is really a terrible thing to see, because cancer should not be inflicting outcomes differently based on people's wealth or circumstances. And we do, and this was mentioned previously, like if you just look at the outcome for men with breast cancer, the survival is lower in men than women. And I think there's a whole lot of reasons for this that, include more advanced stage at diagnosis, which is probably due to lack of public awareness. I think there's probably undertreatment of men with breast cancer. It's not just that, though. So this is an older study. This is one of the actually early studies I did looking at breast cancer in men, and we used data from the SEER registry and looked stage by stage at cancer survival between men and women. And if you look at the top left comparison, you can see kind of maybe not for stage 4, but for stage 1, 2, and 3, men had worse survival than women. Interestingly, though, when we looked at relative survival, these were much more similar. And so what relative survival is it takes into account the age distribution of the patients and the projected life expectancy. So, in the US in general, men are projected to live shorter lives than women. Women on average live longer. So if you take that into account and the fact that they're older, some of these survival differences disappeared, at least back in the study in 2004. This is a more recent study using the SEER data, and I think it's not quite as optimistic. In this study, looking at it, the authors looked, at each individual stage, first of all, and found, especially for stage 1 and 2, that men had worse survival. And then they looked at different subtypes. So looked at the HER2, the hormone receptor positive, HER2 negative. And again, men had worse, stage 1 and 2 had worse outcomes. And then the hormone receptor positive, HER2 positive, which continued to show worse outcomes. So we still have work to do. We should not be having worse treatment outcomes for our male patients. Now I want to just mention briefly the International Male Breast Cancer Program, which I was lucky enough to get to work on with Dr. Schroeder, with Dr. Cardoso, who's going to speak next. So the first part of this was a retrospective analysis of male breast cancer patients. So we collected, again, there's an international group of centers and sites that were willing to participate and donate specimens of tumor blocks from men who had been diagnosed over a 20-year period with breast cancer. The second part of it, we started a prospective registry. So again, the same network of sites enrolled the new patients that came to their center over a 30-month period and collected both biologic material, clinical data, and quality of life. And our third part, which is we're trying to enact still, is to develop prospective trials. So first I'll talk a little bit about the part one. So actually, let me just put these up. So we found, I think, generally a pattern of perhaps a little bit of undertreatment in the male patients. So for surgery, for example, half of patients had T1 tumors. So this is like a 2 centimeter or less tumor, small tumors, but only 4% had breast conservation. For radiation, in the subset of patients where radiation will be indicated, we found that 15 to 36% did not receive radiation. The use of chemotherapy was also relatively low at 30%. And endocrine therapy, even though 90% of men had estrogen positive tumors, only 77% received endocrine therapy. And in about 5% of patients, an aromatase inhibitor was given, which really would not generally consider standard. We did see a significant improvement in survival over time, which was quite encouraging. We saw that estrogen and progesterone receptor are prognostic with higher expression levels associated with better outcomes. And we actually couldn't see any prognostic value for grade or Ki67, which is a measure of proliferation, which is kind of interesting because those are very strongly correlated in women. So the prospective registry, the main reason we really were setting this up was to see whether or not there were enough patients coming through our network of centers that we would be able to do a clinical trial. So we said, let's see if we can get at least 100 new male patients that come through the centers. And if we do, then that's going to be really encouraging that we would be able to conduct a trial. This was very broad, just any man presenting to the center with breast cancer and 18 years or older. And while we were hoping for 100, we actually enrolled 557 patients. So we were so encouraged by them, I mean, not encouraged that there's that many patients with breast cancer, but that we were able to actually capture the patients and show that maybe it would be feasible to do a therapeutic treatment trial so we could really make progress in figuring out how we treat men versus women. This one actually was kind of interesting. BRCA testing is recommended in all patients, but we found it wasn't done in 65% of patients. And again, as you'd expect, we found that the most common hormone treatment was tamoxifen, which was like what 92% of people received. And I think I'll skip over the others. In the US, we've received some supplemental funding from Komen, and we were able to do sample collection also. So we collected plasma, serum, and cell-free DNA samples. And this just shows the different time points that we had samples. So the majority of them were collected at baseline. And then for some patients, we were able to collect 1 year, 3 year, and 5 year samples. So these are all now in cryogene storage at MD Anderson. They're available to researchers who want to use these samples. They're in the US, we collected this through the TBCRC. So there would kind of proposals can go through TBCRC to use this. The study also looked at quality of life. This was led by Dr. Schroeder and Dr. Ruddy. And so they did quality of life questionnaires in men who were diagnosed with breast cancer. And for this, we had 363 patients. The mean age was 67, which is kind of exactly what we would expect. And interestingly, actually looking at all of the quality of life domains, the global health score was actually better reported by men than by women, but there still were issues with symptoms of fatigue, insomnia, and pain. So, this study, I think, really supports the feasibility of doing a therapeutic clinical trial. And I think, the biggest question for us for men is the, optimal endocrine therapies and, what would work the best and be best tolerated for men in terms of endocrine therapies. And then part 3 is really the attempt to do a prospective clinical trial. So through our network, we and Dr. Cardoso deserves an enormous amount of credit for working tirelessly trying to get funding for and drugs for a prospective clinical trial through this network. And that has been very difficult because the pharmaceutical companies typically are not very interested in supporting treatment for such a rare disease. We do have some hope on the horizon, though. I think you just heard about Dr. Schroeder's tamoxifen and testosterone trial, which I think is really exciting. And then you'll hear later today from Dr. Leon about the Ethan trial, which is opening in the US through the TBCRC network. I had slides on these, but I took them out because I don't want to steal their thunder. You're going to hear about this throughout the day. And we're still also working to continue to collect data through registry studies. So the GICAM, a Spanish group, has collected information on 774 male patients, and they are using these specimens to contribute to a whole host of different projects looking at the biology of male breast cancer. So trying to develop a novel male breast cancer predictor tool, and contributing to the Confluence Project, which is looking at kind of the genetic changes in male breast cancer versus breast cancer in women, and then also doing proteomics projects. At Anderson, we also are trying to continue to collect the data. So we're opening the ABC Men study, Advancing Breast Cancer Studies in Men. And again, this will just be a registry, but we see quite a few male patients that come through. We want to make sure that these data are accurately captured and collected so that we can have larger biospecimen banks to do research with and really make progress against this disease. So, our plan is to be collecting survey and biospecimen data from patients at the time of enrollment, and then for up to 5 years. And we're hoping to collect some quality of life information, a depression survey, toxicity scores, and then specimen banking. So I will stop with that and open it up to questions. Again, thank you so much for letting me talk with you today, and I'm open for questions.